In this video, I will cover the presentation of a winging scapula. Expect to learn the following: clinical signs of a winging scapula, what causes it, why simply trying to strengthen the serratus anterior is wrong, and how do we properly address and fix it. For those of you who don't know me, my name is Dr. 𝘚𝘬𝘳𝘳𝘢. I am a soft tissue injury treatment expert. My focus is on diagnosing and treating adhesion, also known as scar tissue, and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which leads to a significant increase in overall functioning, flexibility, and long-lasting pain relief. I'm also the creator of the soft tissue treatment revolution and the program coordinator for Adhesion Release Methods, where we teach overworked manual therapists a new treatment system that will allow them to double their income without working any additional hours so they can stay healthy, avoid that dreaded burnout, and help more people get out of pain. Right, so understanding a winging scapula presentation, clinical signs, causes, why strengthening is wrong for it, and how to fix it. So let's get right into it. So first off is just clinical signs of a winging scapula. You're going to see it, here in the image included in the slide. The scapula is actually going to be kicking out. You're actually going to physically see that. You're going to see a physical change in there. Another couple things you might see with that is some underlying shoulder problems. Maybe there's some weakness in the shoulder motion. Maybe they're having trouble reaching for things, pressing for things. It's letting us know that there's some component of a shoulder problem. And a lot of times when they do have that, it's going to be something on the side here, maybe in the front. They won't actually feel it as much in the back part of the shoulder. They might feel it underneath in the serratus and the subscap area as well. But mostly they're going to come in with some type of shoulder dysfunction. They might have some popping, some clicking, some impingement type of things in there, but they're going to have some type in there, and you're going to see a physical component. I do like to actually look at this from behind, and I have the client bring both their arms up, and then I look at that inferior angle of the scapula, and I see how much more it's traveling out. And a lot of times you can physically see that. That's one thing I like about the winging scapula, is you can actually see it. You can see it present when you're doing a functional evaluation. So what actually causes it? First is it's going to be rotator cuff dysfunction. Specifically in that area is going to be adhesion. I'm going to find it in the posterior capsule, which is actually in the back part of the shoulder, out on the side there. It lives between the posterior delt and the tricep. I'm also going to see it in the infraspinatus, subscapularis, supraspinatus. We can probably throw teres minor in there as well. I usually just include teres minor together with infraspinatus because they kind of live in the same area. And then another area we're going to see problems in there is going to be nerve entrapments, specifically in the suprascapular nerve and the brachial cords and at the subscapularis. There's going to be some issues when you see that as well. Nerve entrapments are really important. I talk about these a lot, but basically what happens is when you have that adhesion formation, it's like glue that gets inside the muscle, but over time it gets bigger and bigger and eventually gets stuck to the nerve. And when it gets stuck to the nerve, it causes numbness, aching, burning, and tension. But when the nerves are getting compromised and they're getting stuck, they're actually going to redline a lot of motions and present with some biomechanical dysfunctions as well. So a lot of times what happens is the winging scapula is actually showing you that there's actually dysfunction in the rotator cuff, and that dysfunction more than likely is going to be some type of adhesion in any of these listed. So why trying to fix it fix the weakness in the muscle is wrong. People are like, oh, you have winging scapula, do the what do they call them? Wall angels or push up plus or something like that. Here's the thing: the weakness that is presenting in the serratus and the winging scapula is actually the effect. It's not the cause. So when the rotator cuff can't produce force how it's supposed to, so most people just think of the rotator cuff as mobility. They think it just moves the shoulder, but it also provides a ton of stability as well, especially in the infraspinatus and the subscap and the capsule. It really locks it down and keeps it in what I call a very protected area. So when the shoulder does move and they do stuff, it can happen. Now, when that happens, it tries to get like a biomechanical advantage. That's why the serratus wings out, because it's just trying to work around that dysfunction. We always want to ask the question of why is it weak? We always default, and a lot of people do in a lot of systems and a lot of techniques default to, oh, something's tight, so stretch it. Something's weak, so strengthen it. We have to answer the question is, why is it weak? why is it tight? Was there a direct injury to the serratus, or is this a compensation? Then really thinking critically, using your brain and figuring out a problem and not just jumping blindly into some type of basic treatment where it's like, oh, it's winging scapula, gotta do this. You don't know that. You have to ask questions. You have to do an evaluation. You have to palpate. You have to slow down. The reason I make a lot of these videos is because so many people are getting improper diagnoses and not getting the treatment they need when they could have got it early in the process. They don't. That problem gets worse. They end up in the orthopedic office getting surgery, pain pills, injections, which make it worse. So if we can clean up the conservative care model and help you think more clinically, then becoming a technician, you're going to be in a much better place and be able to help a lot more people. So first one I talked about, and the priority is we always want to try to treat the nerve entrapment first, because if we don't fix the nerve entrapment first, everything else is going to have a problem. Now, this isn't the type of neuromuscular problem that most people think, where the nerve isn't firing correctly or the muscle is inhibited or weak. It's an actual physical problem out in the periphery. And basically what's happening is that suprascapular nerve is getting entrapped somewhere in that rotator cuff, specifically because that adhesion is forming and it's getting stuck there. Those nerves are built with about 10 to 15% of extra slack to keep them healthy. But eventually that adhesion builds up and it gets stuck there. So two of the most common areas where I do find an entrapment is right below here in what's called the suprascapular notch. That's where the nerve comes in. So it starts up here in the supraspinatus, and then it also gets caught down here right on that spine of that scapula in there as well. And that's where the two most common entrapments of the suprascapular nerve occur in the rotator cuff. You can also find it at the nerve root level, specifically the C5 to C6 nerve root as well. That's where it starts. Most nerves that go out in a periphery have some type of innervation from a nerve higher up, but this is where you're going to find a majority of the problem. I'd say 80 to 85% of my shoulder dysfunction presentations, people with winging scapula, rotator cuff injuries, I'm finding this nerve entrapment being the main thing that I'm treating. And I'm finding the thing with when you're treating the nerve entrapment, though, is you want to be precise and focused. Most people go in and they have way too much compression on it. And all they do is really jam that nerve into that adhesion. Temporarily feels better, but they're not breaking it down. What we want to do is get proper depth and proper tension into the area, then have the client go through a full range of motion. Next area where it can get caught is going to be the brachial cords at the subscapularis. So basically, you have the brachial cords and the brachial plexus that basically goes from C5 to T1, and it basically controls the entire upper extremity. But right on the front part here on the subscap is where those nerves can get entrapped. I tend to see more in the radial nerve, which is actually going to be a little higher up in the armpit there, but you can see some in the ulnar as well. A couple of things that really help me differentiate if it's more of a radial nerve or ulnar nerve is asking them where they feel some other pain down the arm in through there as well. I've made a lot of other videos talking about specifically each one of those nerves, but basically when I have a radial nerve problem, it's going to be more out in the lateral part of the elbow. Ulnar nerve is going to be more in the medial down through here as well. Radial nerve will also have some issues in the thumb and like the web of the hand as well. This area is very important to treat as well. And what I end up seeing here is people are way too compressive. And a lot of times they're not even on the subscap. They're usually on like the lats or the teres. It hurts like hell when you're doing it. You're going in there and just jamming things around. This area is very precise, very focused, very sensitive because you have the brachial arteries, you have the nerves. You just want to get just the right amount of depth and then just the right amount of tension and go really slow. Don't just kill the area. People are always like, oh, I'm treating their subscap, I'm going to beat the hell out of them. No, you're just jamming it. Be gentle. Gentle is better, slow, precise, and focused. Next one where I do find some issues as well after I've cleaned up all the nerve entrapments is going to be in the posterior shoulder capsule. It basically lives between the posterior delt and the tricep as well. The capsule is like a ball of ligaments, and it's really important in creating stability and just overall function in the shoulder. And what happens a lot of times when that shoulder's in a bad position, maybe rolled forward or down, that capsule gets stretched. And when it gets stretched, it develops more and more of that adhesion, then just in turn puts more wear and tear on the shoulder. And that's why that serratus is presenting as a winging scapula and having issues in there as well. So when should we build strength back up? A lot of people are like, well, it's weak, we got to strengthen it. Yeah, we do, but it's an order of operations. Think of an injury as like a really bad house, and we need to go and just tear it down and get the tissue healthy. That's where we come in as awesome soft tissue providers. We got to do the first work. We're the first person that someone should see when they're injured. Then we can kick it up and down the road to physical therapists and strengthening as well. But there's an order of operations to fix anything. Number one is first, we just need to increase overall range of motion. So when an injury is present, it's going to have limited range of motion. And more than likely, that's going to be caused by the adhesion formation in the muscle, in the fascia, or the nerve entrapment. So our job as manual therapists is identifying where that is, putting it in a shortened position, getting proper depth, proper tension on it, having the client go through a full range of motion and breaking that down. It's going to make a physical change in the tissue. Then once we do that, we need to balance the strength. And with that, I do more of a corrective type of approach. So basically with that, it's going to be more like a single joint, maybe some side lying, an overhead press, or something like that to build that strength back up. Because when I said you have the adhesion, you get decreased flexibility. We also get weakness, and we got all the flexibility back by treating the adhesion. Now we need to build the strength. And then the last one is we just need to go in there and increase the strength globally. That's when I do more like multi-joint type of exercises for the shoulder. I really like to do an overhead press and then hold it and then have them do a carry as they walk around. That's going to really help build up that overall strength. But you want to stick to the order of operations. It's like if you're trying to strengthen the area, but the tissue isn't healthy, it'd be like trying to fix a cavity by brushing and flossing. It's past that point. So you want to follow the order of operations, but understand identifying and fixing the adhesion is going to be the most important part. It's going to be the start of everything. It's going to lay the foundation for everything so that it works and gets that client the results that last and gets you the reputation of being someone that can truly solve a problem. That's all I got for you in the video. I appreciate you watching. If you like anything that we're teaching or we're showing, you can go and download and access our free training modules. Honestly, they're better than, I'd say, 99% of paid courses out there. They're full of a lot of useful information, getting you on the path to thinking critically, becoming a problem solver, producing solutions for your clients, and not just getting stuck, in the rat race of trying a bunch of different treatments and never really knowing what happens. We teach you how to think critically, figure out that problem, get it right every single time so you can get the reputation of being the best of the best in your area. Appreciate you watching the video, and we'll catch you on the next one. Bye.